Thank you so much, Beth, for inviting me. It's great to have a chance to speak to to everyone here on the last day of the symposium. Going after Dr. Sharma is definitely challenging, but I'll do my best. So the task that I've been given or assigned is to talk about dual or triple therapy post-PCI. This is an area that is definitely very challenging. It's evolving very rapidly, and it's confusing. You know, we have a lot of new drugs coming out. You just saw some of the data Dr. Sharma shared with respect to dropping aspirin, and it's certainly confusing for us. It's certainly confusing for our patients, and I'm not going to pretend that I'll be able to answer all these questions, but I hope to at least distill some of these concepts and highlight some of the salient points that you can hopefully take away and equip you to sort of speak to your patients and take care of them in a better manner. So what I'll do is start off with talking about the rationale for DAPT, then rationale for oral anticoagulation, OAC, the issue of triple therapy, bleeding risk, and some evolving paradigms. And one of the points I'm going to reinforce over and over, and this is something I tell my students, my fellows, is that in clinical practice, we often get accustomed to sort of doing things because we're just sort of told to do them. You know, why do you give DAPT? Well, that's what you're supposed to do. Why do you give oral anticoagulation? That's what someone told me to do. Why do we give Lipitor 80 after MI? But if you actually challenge yourself and go back, look at the original trials and the studies, I think you will remember these things better. And again, be able to take care of your patients in a more effective manner. So let me start off with DAPT after PCI. Why exactly do we do this? As we all know, in the coronary circulation, when we are doing angioplasty or stent, this is actually a traumatic procedure. You're damaging the vascular endothelium, you're liberating material into the bloodstream that can induce thrombosis. This is no different, by the way, when someone has a spontaneous MI. There's a plaque and it ruptures, and that induces a prothrombotic milieu. And therefore, naturally, we want to suppress that early thrombosis. And if we go back to the mid to late 1990s and early 2000s, we didn't know what to do. We knew when we put stents in human coronary arteries, we caused this prothrombotic state, but we didn't know how to mitigate those early thrombotic events and take care of our patients. So this is the STARS trial. This is the key trial, 1999, 1,500 patients, 30-day outcome. And take a look at what the treatment arms that were under consideration. You have aspirin alone, aspirin plus warfarin, and then finally aspirin plus ticlopidine are two inhibitors of platelets. And the results were very clear. The patients that did the best were those who got two inhibitors of platelets, namely aspirin and ticlopidine. And the other lesson from this trial not only was that we had to use DAPT, but the way we defined DAPT was that you have aspirin as a foundation to which you add on another drug. So this set the stage. 1999, it was this trial, this observation that clearly taught us if you want to prevent early thrombosis, you've got to give your patients two drugs that inhibit the platelets in separate ways, one being aspirin, one being a P2Y12 inhibitor. This observation was then confirmed in other studies, and in the CURE study, we found that these benefits were not only early in that first couple of weeks, but actually durable out to a year. So in the early 2000s, late 1990s, we have some important lessons to us. We find out, number one, that DAPT is the best way to prevent thrombosis. We learned that the definition of DAPT is aspirin foundation to which you add a P2Y12 inhibitor. And third, we have to give these drugs for at least about a year. That's how you can optimally take care of patients. So that is are the early lessons with respect to DAPT. What about oral anticoagulation? Well, again, everyone knows when we're talking about our patients who have atrial fibrillation, our main concern is a strong association between atrial fibrillation and stroke. Well, around the same time we were trying to figure out what to do with patients getting stents, there were a group of investigators, and these are in these red rows here, who were studying patients with afib. Now, these are fundamentally different patients. If you just kind of take a look at these studies here, most of these patients didn't have a lot of CAD. They weren't really enriched with history of prior MI. These were fundamentally different patients. And what the investigators were trying to do in these early studies is they were trying to figure out what are the factors that correlate with stroke. We know AFib patients get stroke. What we're trying to figure out is exactly what are the key factors that predict stroke risk in these patients. And everyone is familiar with the CHADS algorithms, where these are the original papers that actually introduced us to this concept. On the top left is the original paper published in 2001. This is the CHADS-2. And on the right is the current iteration that I think most people are comfortable with, this is CHADS-2 VASC. The blue indicates the various factors that contribute to the CHADS-2 VASC score. And this score is very nice. It's intuitive, it makes sense, it's easy to calculate. And biologically, I think it makes sense as well. It sort of makes sense that if you have hypertension, you're elderly, if you have diabetes, prior stroke, you're at higher risk for having a subsequent stroke. Also, if you look at the right, it gives us a nice way to quantify subsequent stroke risk over a year. So the more numbers you have, the higher is your CHA2-VASc score, the higher is your risk for having a stroke over the ensuing year. So these studies, again, conducted more or less around the same time, are giving us lessons into what are the factors that portend risk for stroke in patients with AFib. However, the question still remained. How do we take care of these patients? Around this time, we had DAPT coming out to us. We knew DAPT was good for ACS. We knew DAPT was good for patients with PCI. Well, maybe DAPT could also be good for patients with AFib. So this was actually studied in a trial. This is the ACTIVE-W trial. And what they did here is they took patients who had atrial fibrillation. They asked the question, should we give them DAPT, namely clopidogrel plus aspirin, which was now the standard of care in patients with PCI and ACS, or do we have to give them oral anticoagulation, which at this time was primarily going to be warfarin? Here you'll notice these curves are upside down to what you saw in the STARS trial. Here, the patients who got DAPT did the worst. Patients who got anticoagulation did the best. So in the AFib population, you see a complete reversal of the paradigm that we had gotten accustomed to in the space of PCI and ACS. And the reason for that, I think, can be understood if you look at what these patients suffer from over the ensuing years. In AFib patients, the number of strokes in this trial was 132. The number of MIs was only 59. So in the AFib population, these patients are burdened with having a much higher risk for stroke over the future. This is not really a platelet-mediated phenomenon. This is a phenomenon wherein we have to suppress underlying the coagulation pathways, and that is best done by warfarin or the NOACs, which is what we use nowadays. So again, just to hammer this point home, because I think this is an important concept that we don't really quite appreciate, AFib patients and PCI-ACS patients are two different phenotypes, they're two different substrates, and therefore our treatment strategies also have to reflect that nuance. On the left, the ACTIVE-W trial, as I just mentioned, their risk for stroke far exceeds their risk for an MI, and therefore your strategy has to be one where you're going to focus on coagulation pathways. In contrast, on the right, in patients who are coming with an acute MI, their risk for MI far exceeds their risk for stroke, and therefore the strategy has to be focused on preventing risk future MI, and we know that is dual antiplatelet therapy. So those are the key kind of seminal trials and concepts that allowed us to understand the foundations for DAPT, foundations for oral anticoagulation, and now I want to talk a little bit about triple therapy and bleeding risk. It's sort of, intuitive. If we add all of these drugs together, we're going to be in a lot of trouble with respect to bleeding. On the left, as I just mentioned, you are obligated in your AF patient to give oral anticoagulation. You are obligated in a patient who has an acute coronary syndrome or a stent to give dual antiplatelet therapy. You couple those two together, we have what we call triple therapy, and that, of course, leads to bleeding. Now, the challenge that many people have is they think of bleeding as sort of an issue that is not really that important. You can reverse it, you can transfuse patients, you can monitor them, it's transient, you can recover, so why should I care about bleeding so much? Well, hopefully what I can convince you of is that kind of thinking is a little bit sort of outdated, and the reason it's outdated are a series of studies that were conducted that alerted us to the very important issue of bleeding and risk for mortality. So this is one of the earliest studies, and I think this is a very nice insight. This is a study looking at patients with acute MI. And what they did is they looked at mortality over just 6 months, and they looked at mortality in relation to the degree of bleeding. Now, it is not surprising if you have a life-threatening bleed, you have a higher risk of death, okay? So if somebody has an intracranial hemorrhage, if they're exsanguinating and they're getting hypotensive, obviously their risk for mortality is high. The insight from this study is this middle curve right here, the major bleeds. These are the ones we see all the time. They come in, a couple gram drop in hemoglobin, maybe you transfuse them, you call GI, you do an endoscopy, you take care of them, and they go home in a couple of days. Look at their risk for bleeding over the ensuing 6 months. It approaches 10%. So even though this is transient and presumably okay, and you take care of them and you send them on their way, these patients, once they suffer that bleed, are at very high risk for subsequent death. And it's not just early bleeds, but also later bleeds. Again, when someone comes into the hospital, we're giving them a bunch of antithrombotics or an acute MI syndrome, we're really testing their thresholds of sort of their clotting, inherent clotting physiology. And so if you bleed early on, it kind of sort of makes sense you're going to do poorly. But what about in the outpatient setting? The patients come in, they had their MI, you've taken care of them, now they're home. Well, if you bleed then, later bleeding, you also have a very high risk for mortality. So bleeding is important, not only if it's early, but also if it's late. And then Dr. Moran, about 10 years ago, was the first to teach us this lesson. And in this study, what they actually try to do is ask the very important question of which factor matters more? Is it the bleeding or is it the MI with respect to mortality? And again, point your attention to this forest plot here. And what this plot does is it tells you the mortality risk in relation to an MI. So when you have an MI, your risk for mortality is very high in the first couple days, but then it degrades very quickly. So about a month or so after an acute MI, your risk for a future MI is no different than if you never had one. Look at what happens with bleeding. When you have a bleed, you have an early risk for death, but that early risk is durable. It doesn't degrade as much. So this was really among the first studies that taught us a very important lesson. Number one, the mortality risk after a major bleed approximates that after an MI. Number two, that mortality relationship in context of time is more durable after a bleeding than an MI. So our priorities from a clinical standpoint when we take care of our patients should not favor one or the other. In fact, we have to think about both of them in unison. So what are some of the evolving paradigms? So how can we take care of both of these issues? How can I take care of bleeding and MI simultaneously? The traditional approach in medicine has been we start off with one drug, then you add another drug, then you add another drug. Our approach is naturally to find drugs to take care of the issue at hand. Well, Professor Pocock and Bernie Gersh wrote this very nice article that actually said what we need now in medicine is not to do more, but to do less, and to actually devise trials that can investigate the withdrawal of certain medications. So the paradigm we're in now and the arena we're in now is finding ways to change our approach, our pharmacotherapeutic strategies, wherein we actually maybe take away medications, are safer, and at the same time don't incur any harm. And as Dr. Sharma had mentioned, one area that has become an important target has been the issue of aspirin. So when we look at our AF patients, this was the first trial that actually tested in patients with atrial fibrillation getting rid of aspirin. So these are patients with AFib undergoing PCI. All of these patients got warfarin. All of these patients got clopidogrel, but one arm got aspirin, that's a triple therapy arm. One arm did not get aspirin. So this is the first trial, about 500 plus patients, a very provocative study because it was the first time anyone challenged the primacy of aspirin or the supremacy of aspirin after PCI. And the results were very clear. In blue, you see the patients who only got two drugs. In other words, they got rid of the aspirin. They did much better by about 25%. So the first time we saw in stented patients with AFib, you can get rid of aspirin. This has since now been basically duplicated with the NOACs. This is the Pioneer AF trial where they used low doses Xarelto plus clopidogrel. Again, no aspirin. This was the real experimental arm compared to two other arms, and the results here were also very clear. The experimental arm where you got rid of the aspirin here in the yellow did much better than traditional triple therapy with warfarin over a 1 year time point, and also there was no incremental risk for thrombotic events. And then the most recent study is the Augustus trial, now using Eliquis. So you can get an eye flavor what's happening. All the manufacturers of these different drugs are doing their own trials. We have the Pioneer with Xarelto, we have Eliquis, and again, these findings were just presented, and I think these are the strongest data so far, and here are the primary results. At the very bottom, you can see the patients who got Eliquis plus the P2Y12 inhibitor alone. Again, these are patients with AFib undergoing stenting. If you just give them Eliquis plus a P2Y12 inhibitor, they do the best. Who does the worst? Patients who are getting all three drugs at once. The little nuance in the study, however, there was numerical differences where the patients who got aspirin did have lower rates of stent thrombosis and MI, so there was a little bit of caution and a suggestion maybe we can't get rid of aspirin in all patients, but in select patients. So to put these things into perspective, a white paper was put out by Dominic Angelillo and colleagues to help guide us. And basically the concept from this paper is that what you're supposed to do is look at your patient, think about the ischemic risk, think about the bleeding risk, and then tailor the strategy to that risk. So if the ischemic risk is high, you give them triple therapy maybe for a couple of months, and then you get rid of the aspirin. In contrast, if the bleeding risk is high, you truncate the duration of triple therapy and then go to dual therapy much quicker. Now, I'm going to tell you that while this is sort of one thing to discuss and write about and sort of publish on, this is confusing. I think this is confusing for those of us who are spending our time in investigating this. I think this is confusing to transmit. And what about patients? In all of this conversation, we haven't really thought about what are the patient's priorities. We're sort of assuming that MI and bleeding are equivalent with respect to mortality and all these numbers and estimates. What about if you ask a patient? How many bleeds is a patient willing to sustain to prevent an MI? What is their calculus? And that really is not part of this conversation, and I think is an important issue. So to sort of address that, we actually conducted I'm just going to go through we conducted a study called the Aviator Study. This was a study run right out of Mount Sinai. Dr. Rand was the principal investigator. I was fortunate enough to present these at Sky a few weeks ago. This was a registry where we took these patients who have AFib undergoing stenting. So the patients I've been talking about this whole time, afib PCI. This is a registry, and we just wanted to see how these patients were treated and what factors influence decision making. We had a host of sites around the world. And this was the study schema. So what we did in this study is we tried to actually ask both physicians and patients about their own priorities and their own perceptions of risk. We developed an app for this. So we asked physicians, tell us what is your perception of risk in your patient. We have the CHAD scores and all of that, but we actually asked the clinicians, tell us what you think your own risk perception is in your patients. We also asked patients, what are you worried about? And how well do you understand the medications you are being given? And then we followed patients over time, 514 patients. And this was a key insight from this study. These are weighted scatter plots. I'll walk you through what these are telling us. The x-axis here on the left is the CHAD score. Again, remember, these are AFib patients undergoing stenting, so they have CHAD scores. So here you have that on the left. The y-axis is that clinical perception. We asked the physician to grade and to weight what they thought how risky their patients were. What you will notice is that when the CHAD score is low, when they're at low risk, clinicians are overestimating. They're thinking the patients are riskier than they truly are. In contrast, when the CHAD score is high, you see the weight is over here. Clinicians are underestimating risk. You want to put it a little bit more simply, in patients who have a high CHADS-VASc score, everyone here who's been taking care of these patients knows high CHADS-VASc, you got to have anticoagulation. But when you ask clinicians, they only perceived 44% of those patients as being at high risk. So clinicians are making a very poor judge of risk perception in their own patients. We saw the same thing with HAS-BLED. Among patients with a high HAS-BLED score, which is a risk score for bleeding, clinicians only perceived a third of them as being at high or very high risk. So we can talk all we want about CHAD scores and different approaches and clinical trials. At the end of the day, the people on the front lines who are making these decisions are doing a pretty poor job of even assigning risk appropriately. And what about patients? Where do patients fall into all this? Well, we ask clinicians, what are the factors that drive your decisions? You will find overwhelmingly that clinicians felt that safety, namely not causing bleeding, and efficacy, namely preventing stroke, were equivalent. We are taught to do no harm, and therefore I think naturally we are driven to think of safety as much as efficacy. We can't disentangle those. Patients have a very different take on this. On the right-hand side, you will see what patients were worried about was overwhelmingly issues of efficacy. They were worried about a heart attack. They're worried about stroke. They're worried about preventing death. Issues related to bleeding or getting frequent blood tests is much, much lower. And none of these sort of weightings or priorities have been taken into consideration in all of these studies, and I don't think really are taken into consideration in our day-to-day practice thus far. And finally, I think I just want to end with these couple of slides, and the purpose here is to illustrate with studies like the Aviator Registry and with the complexity of an issue of dual or triple therapy and how we weight these issues, we're moving to a very different healthcare ecosystem. No longer is it a vertical issue where the doctor just talks to the patient and they go about their merry way and do what they're supposed to do, but we have to think about the ecosystem in concert, the patients, the care coordinators, everyone, and if we don't do that, we're going to miss out. Patients are going to get confused, they're not going to know what to do, and patient outcomes are going to be poor. And with use of technology, we're hoping, and some of the work, as Beth alluded to, we're hoping to leverage some of these technologies to actually do a better job of tracking patients, getting them more adherent, and ultimately, hopefully, getting them to understand why it is we want them to take certain drugs and ultimately do better, not only for them, but for the healthcare system as a whole. So in conclusion, DAPT is obligatory after ACS or PCI. That's the STARS trial, late 90s, early 2000s. Oral anticoagulation, we know, is better to lower stroke risk. That's that active trial. It's much better than DAPT. Bleeding risk is certainly increased when you put everything together, but it is as a strong predictor of death as is MI, and therefore one must think about these equally in decision making. Recent studies do suggest that a dual strategy of a novel oral anticoagulant plus clopidogrel is probably optimal in most patients, and those of you who have been taking care of these patients know that's what we're doing more and more. And finally, I think patient-centric approaches that really take into account their wishes, their priorities, we can't assume that we actually know and understand these, within the context of a cohesive healthcare paradigm should really be the default strategies as we move forward in our daily practice. So with that, I'll conclude. Thank you.